Patients here.
Oh boy, got some blood going.
Yeah, there's never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
your left
hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
All right, let's do this. I want you to close your eyes for a second. When you picture pediatric nursing, what is the first thing that pops into your head? Be honest.
Usually it's kind of the Hollywood version, the cute patterned scrubs with cartoons on them. Maybe you've got a sticker collection in your pocket.
Yeah.
Giving a brave kid a lollipop after a shot. It looks soft.
It looks easy.
Yeah, easy.
Right. It's the soft side of nursing. But when we actually dig into the literature, and specifically this heavy hitter chapter we were looking at today on atraumatic care, you realize pretty quickly that the sticker and the lollipop, they're just the tip of a very, very complex iceberg.
Oh, absolutely.
I mean, there is a massive clinical chasm between just being nice to a kid and practicing, evidence-based atraumatic care.
Absolutely. And the stakes are just incredibly high. It is literally the difference between a child who is traumatized by a simple procedure, we're talking screaming, fighting, requiring 3 adults to hold them down, versus a child who actually copes successfully and walks away with their dignity intact. And that is exactly what we are unpacking today. This concept of atraumatic care isn't just a buzzword. I mean, the source material calls it the prime directive of pediatric nursing.
It's almost like the first do no harm principle, but specifically calibrated for a developing brain that has zero context for why a stranger in blue pajamas is coming at them with a sharp object.
That's a perfect way to frame it, yeah. And for our listeners today, our learners, whether you are a nursing student just sweating over NCLEX prep or a new grad stepping onto the PEDS floor for the first time, our mission today is really specific.
We're going to strip away the fluff. We are looking at this chapter through the lens of the 80-20 rule. We want to identify that 20% of the information that is going to help you answer 80% of the exam questions and, frankly, solve 80% of the problems you'll face in practice when it comes to communication, safety, and procedural prep.
And we've got a stack of notes here from the source text, really focusing on preventing stressors, the nuance of communication across different developmental stages, which is huge.
Huge.
And, of course, the critical piece of family education.
Okay, so let's jump right in with the foundation. What is the actual textbook definition of atraumatic care we are working with here? Because I think people assume it just means painless, but it seems to be much more comprehensive than that.
It is significantly broader. So the text defines atraumatic care as therapeutic care that minimizes or eliminates the psychological and physical distress experienced by children and their families.
Mm-hmm.
And I really need to highlight that last part.
Their families.
Their family.
Because in PEDS, you never just have one patient. You have a unit.
Exactly. You cannot treat the child in a vacuum. It's a package deal. If the parent is spiraling, the child is spiraling. We often say anxiety is contagious in a pediatric room. So the text breaks this down into a framework. It's not just be nice. There are 3 specific principles listed in box 8.1 that kind of act as your compass.
Okay, let's drill down on these. If I'm taking notes right now, what are my 3 pillars?
Okay, so pillar number 1, prevent or minimize physical stressors.
So that's the pain piece, right?
Pain, yes, but it's more than just, nociception. It includes sleeplessness, immobility, loud noises, or even just the inability to eat or drink. NPO status is a huge physical stressor for a child. Anything that physically taxes the body or just disrupts their physiologic norm.
Got it. Okay. What's number 2?
Number 2 is prevent or minimize parent-child separation. This ties directly into that whole philosophy of family-centered care.
And this seems so obvious now, but historically, this really wasn't the case, was it? I mean, I've heard horror stories from decades ago.
Oh, not at all. In the old days of nursing, and we're not talking ancient history here, maybe 30 or 40 years ago, parents were routinely asked to leave the room during procedures. The thinking was, that the child would behave better without an audience. It was very paternalistic.
Right.
And the data now just tells us that is usually the absolute wrong move. Separation anxiety is a massive stressor, and it's often worse than the pain itself.
Wow. So keeping them together is actually a clinical priority, not just a courtesy. And the third pillar.
Promote a sense of control. I mean, think about it. Hospitals are control-stripping environments by design. You eat when we say, you sleep when we say, you get poked when we say, you wear this gown that opens in the back. For a child who is just learning autonomy, this is devastating. So atraumatic care means aggressively giving that control back wherever possible, respecting rituals, giving choices, protecting privacy.
I want to pause on that because this feels like a massive hack for answering test questions. I call it the Pareto principle application here.
Yeah.
If you get a tough scenario question like, why is the nurse allowing the mother to hold the child's hand during the IV start? Or why are we asking the child which arm they want the blood pressure cuff on? The rationale almost always maps back to one of these three things.
That's a great strategy. It really is. If you are stuck on a question, stop and ask yourself, does this answer choice support the parent staying? Does it give the child a choice? Does it reduce physical pain or discomfort? If the answer is yes, statistically, it is very likely the correct answer. The exam wants to see that you prioritize the child's emotional safety as much as their physical safety.
So let's get specific on that first pillar, managing physical stress. Because the text brings up something that I think is a huge light bulb moment for a lot of students about how we physically handle children, the restraint trap.
Yes, this is so critical because it addresses a practice that was standard for decades, but is now, recognized as potentially harmful.
Yeah.
Historically, if a child needed stitches or an IV, you'd have what was effectively a papoose board, which is exactly what it sounds like, a rigid board with Velcro straps.
Oh, wow.
Or you'd have 3 adults just holding the child down flat on the bed.
Which, if you think about it from the child's perspective, is terrifying. I mean,
Yeah.
being overpowered by giants, it's like an abduction scenario.
It induces panic. And physiologically, panic increases heart rate, it increases vasoconstriction and muscle tension, which actually makes finding a vein harder, and it just burns trust. The source material here pushes very, very hard for a different concept called therapeutic hugging.
I love that term. It sounds soft, but it's actually a clinical technique, right? This isn't just cuddling.
No, not at all. It is a defined clinical intervention. It's a holding position, usually chest to chest or sitting on a lap, that provides close physical contact while still securing the limbs necessary for the procedure. Figure 8.1 in the text illustrates this beautifully.
So instead of pinning them to the bed, the child is sitting up, maybe even engaging with the parent.
Right, exactly. So for an injection, the child sits on the parent's lap. The parent hugs the child's upper body and secures the free arm while maybe trapping the child's legs between their own legs. The goal is to replace holding down with holding close. You're leveraging the parent's body as a source of comfort, not as a restraint mechanism.
And here's where it gets really, really interesting for the exam and for practice. There's a specific trap regarding the parent's role in this. Because you might think, great, mom is there, she can hold the arm down.
Correct. And that is the NCLEX trap. You should never ask a parent to restrain their child.
Wait, really? Even if they are right there and they're willing, even if they say, I've got him.
Even if they are right there, you have to understand the psychology of the parent-child bond. The parent is the safe base. They are for comfort, protection, and holding. If the child needs to be firmly secured for a painful procedure and it requires force that might cause the parent distress, the nurse or another staff member should do the securing.
Why is that distinction so important?
Because you don't want the child associating the parent with the force being used against them. If mom is holding me down while I'm in pain, mom becomes part of the trauma. The parent's job is to whisper in their ear, hold their hand, distract them, and be the comforter immediately after. The nurse is the bad guy in that moment, if necessary, so the parent can remain the hero.
That is such a crucial distinction. Parents comfort, nurses secure. But the text mentions another player in this game who is basically the MVP of atraumatic care, the child life specialist, or CLS.
Oh, yes. If you see child life specialist as an option on an exam question, you should strongly consider picking it. The text describes them as a quality benchmark of pediatric care.
I think there's a misconception that they are just the play ladies or play guys who bring the iPad or the coloring book.
It's a huge misconception. They are clinicians. They are trained in developmental psychology and the impact of illness on children. They provide non-medical preparation, advocacy, and therapeutic play. They bridge the gap between the scary medical world and the child's world.
So if I have a 6-year-old who is absolutely terrified of an upcoming surgery, I'm not just winging it, I'm calling the CLS.
Exactly. They have tools you don't have. They can use anatomical dolls to show what an IV looks like. They can take the child on a tour of the OR to demystify the room. They can advocate for the child's needs during the procedure. The takeaway here is utilize them. It's an interdisciplinary team, and the CLS is the expert in coping.
Okay, moving on to what I think is really the meat and potatoes of this deep dive.
Yeah.
Section 3, communication and preparation by age. Because, let's be honest, how you talk to a 2-year-old is completely useless if you try that same strategy on a 12-year-old.
It's worse than useless. It can be detrimental. You absolutely have to match your communication to their developmental stage. This is where those questions about which statement by the nurse is appropriate come from on the boards. And this is where we can really lean on those developmental theories, PEDI and Erickson, that are usually running in the background of these chapters.
So let's break it down chronological order, starting with infant's birth to 1 year. They can't understand your explanation of a procedure. They don't know what a needle is, so what matters?
It's all about sensory input: touch, sight, hearing. The text emphasizes soft vocal tones, cuddling, rocking, singing. From an Erickson standpoint, this is the trust versus mistrust stage. Everything we do should reinforce that the world is a safe place. But there's a key safety tip here regarding stranger anxiety.
Oh, right. That kicks in around 6 to 8 months usually.
Exactly. Before about 6 months, they're usually pretty chill with whoever holds them. But once stranger anxiety hits, if you just walk in and immediately swoop down to pick up a 9-month-old, you're going to trigger a meltdown.
So what's the play? How do you assess a baby who hates your face?
The strategy is talk to the parent first, keep your distance initially, let the baby watch you interact safely with the parent. Stand at the doorway, use a soft voice. Once the baby sees mom trusts this person, mom is smiling at this person, they will take their cue from the parent and warm up.
That's the warm-up period. Essential. Okay, moving up to the chaos agents. Toddlers, 1 to 3 years, and preschoolers, 3 to 5. This is a fun group, but tricky.
Very tricky. Cognitively, this is where PEDI calls them egocentric. They see the world entirely from their own perspective. They can't view things from another person's point of view. If their eyes are closed, they genuinely think you can't see them.
And they interpret things so literally. And we'll definitely get to the vocabulary in a minute.
Right, and they engage in what we call magical thinking. So they might think their illness is a punishment for being bad. Reassurance is absolutely key.
So how do we prep them? If I have to do a dressing change on a 3-year-old, what am I doing?
For toddlers, you want to use parallel play. They might not play with you, but they'll play next to you. So you start playing with a toy near them. For preschoolers, you can use puppets or storytelling. But the high-yield fact here, the one you absolutely need to memorize, is the timing of the preparation.
This is a classic test question. When do I tell a 2-year-old they're getting a shot?
For a toddler, immediately beforehand.
Immediately?
Yes. Their concept of time is basically non-existent. If you tell them in the morning, you're getting a shot this afternoon, you have just condemned them to hours of anxiety they can't process. They will act out, they won't eat, they will cry. You tell them right as you are about to do it.
And for preschoolers, a little different.
You can give them a little more runway, about 1 hour prior. It's just enough time to process, maybe play it out with a doll, ask a question, but not enough time to stew on it all day.
And control is big here too.
Right.
Because toddlers are all about autonomy, that me do it stage.
Huge. But it has to be a valid choice. This is the classic rookie mistake. Asking a toddler, can I check your blood pressure now?
Because they will say no.
Every single time. And then what? You have to do it anyway, and you've just broken trust. You made them think they had a choice, and then you overruled them.
So how do we frame it then?
The correct approach is, do you want the blue cuff or the red cuff? Or do you want to sit on mom's lap or the chair?
Yeah.
You give them a choice where the outcome, the procedure, is not up for negotiation, but the method is.
I love that. Do you want the blue Band-Aid or the red one? It seems so small to us, but for a 3-year-old, that's their whole world. They control the Band-Aid.
Exactly. It turns a violation into a collaboration. And it fulfills that Erickson need for autonomy versus shame and doubt.
Okay, graduating to school-age kids, 6 to 12 years. This is where they start to get a bit more logical.
Now we see a shift. Cognitively, they're interested in the why and the how. They want to know how things work. They are in that industry versus inferiority stage. They want to master things. They want to know what the blood pressure cuff does.
So this is where we can pull out the diagrams.
Yes. Diagrams, illustrations, videos. Show them the equipment. Let them touch the stethoscope. Demystify the tools. They are also very responsive to third-party stories.
What does that look like?
So you can say something like, some children tell me this feels like a pinch, but then it goes away. It validates their fear without telling them exactly how they have to feel. It normalizes the experience. It helps them feel like they aren't the only one who has ever had to do this.
And timing for prep here.
A few days in advance, they have a better concept of time. They need a few days to think about it, ask questions, and mentally prepare.
Okay, and finally, adolescence. The 13 to 18 crowd, this can be a tough crowd to win over.
The priority here shifts completely to psychosocial needs: privacy, body image, and independence. This is Erickson's identity versus role confusion. They are trying to figure out who they are separate from their parents. You need to talk to them like adults, respect confidentiality, and realize their peer group is, well, everything.
And what about parents being in the room? The 15-year-old, that dynamic totally changes.
You should offer the choice. Do you want your mom to stay for the exam, or would you prefer she step out? Give them that autonomy. They might want mom there but are too embarrassed to ask, or they might desperately want her out so they can ask you a private question.
And prep can be up to a week prior.
Yes. You can treat them as partners in the decision-making. Explain the long-term benefits. Engage their abstract thinking skills.
There's a note in the text here about regression that I think is worth flagging before we move on, because parents freak out about this.
Oh, yeah. Regression is a defense mechanism. Is when a child under stress reverts to an earlier developmental behavior. A fully potty-trained 4-year-old might start wetting the bed in the hospital. An independent 14-year-old might suddenly want their teddy bear or want to be hand-fed.
And the parent thinks, oh no, we've lost all our progress.
Right. And the nurse's job is to reassure the parents that this is a normal stress behavior and it is not permanent. Don't shame the child. Don't say, you're a big boy, why are you acting like a baby? Just support them, and when the stress resolves, the skills will come back.
So important. Now, speaking communication, let's move to section 4, the vocabulary of fear. This is one of my favorite parts of the chapter because it's just so eye-opening. We use these medical words every day. They're just technical terms to us. But to a kid, they can sound like a horror movie script.
It's that literal thinker problem again. Table 8.2 in the text is a goldmine for this. It lists terms to avoid and terms to use. If you just memorize this table, your interactions will improve overnight.
Let's run through the taboo list. I'll give you the medical term. You tell me what the kid hears and what we should say instead. First one, dye. Like, we're going to put some dye in your IV for the CT scan.
To a child, die sounds exactly like die, as in death. You are effectively telling a literal thinking child, we are going to put something in your veins that makes you die.
That is absolutely terrifying. I can't even imagine the panic. So what do we say instead?
Special medicine to help the doctor see inside you better.
Okay, next one. Stretcher.
Sounds like stretcher, like some kind of medieval torture device. Imagine a 4-year-old thinking you're going to put them on a machine that stretches them out.
Yikes. So a better option.
Rolling bed or bed on wheels. Keep it descriptive and simple.
How about monitor?
Sounds like monster. It's an easy slip. Just use TV screen.
And here's a big one. Deaden or put to sleep.
This is a huge trap. So many children have had a pet, a dog or cat, that was put to sleep, and that pet never came back. That pet is buried in the backyard. If you tell a child, we're going to put you to sleep for surgery, they might actually think you are euthanizing them.
I never thought about that connection, but wow, it makes total sense. So special sleep.
Special sleep, or numbing medicine, and you have to make it explicitly clear they will wake up. You will have a special sleep so you don't feel anything, and then we will wake you up when we are all done. You have to bridge the gap to the waking up part.
One more. Taking your vitals. Take your blood pressure.
The word taken implies theft. I'm going to take your blood pressure. The child is thinking, wait, I need that. Don't take it away from me.
It sounds funny to us, but it's logic to them.
It is. Instead say, I'm going to measure how warm you are, or hug your arm to see how strong your heart is.
It's amazing how these small word choices can prevent a massive anxiety spike. It really emphasizes that language is a clinical tool. We have to be as precise with our words as we are with our dosages.
Precisely. It costs nothing to change your vocabulary, but the payoff in atraumatic care is immense. You are removing the accidental trauma we inflict just by speaking carelessly.
Let's zoom out a bit to the bigger picture in Section 5. Family-centered care and cultural safety. The text says, treat the family as the patient.
That is the philosophy. The family is the constant in the child's life. We are just visitors. We're there for a shift or a few days. The family is there forever. If you don't win over the family, you won't win over the child. And a big part of that is respecting cultural diversity and addressing language barriers.
Box 8.4 talks about interpreters. And this is a critical safety issue for the NCLEX and for real life. I feel like we see this mistake happen all the time in practice.
We do, and the golden rule here is absolute. Do not use family members as interpreters.
Not even if the teenage daughter speaks perfect English and offers to do it?
Especially not then. There are 3 reasons why this is so dangerous. First, it's a breach of confidentiality. The patient might not want their child knowing their medical business. Second, medical terminology is complex. A teenager might not know how to accurately translate congestive heart failure or informed consent.
And the third reason.
It puts an immense emotional burden on that family member. I mean, imagine asking a child to tell their parent they have cancer, or asking a sibling to explain a painful procedure. That is not their job. You must use a qualified medical interpreter.
And there's a specific technique for how to use the interpreter, right? When the interpreter is there, or on the iPad, who do you look at?
You look at the family. You talk to the family, not the interpreter. It builds rapport. If you stare at the interpreter the whole time, the family feels excluded from the conversation about their own child. You look at the mom, you speak, the interpreter translates, you keep looking at the mom.
Good point. And pacing matters too.
Oh yeah, speak slowly. Pause every few sentences to let the interpreter catch up. Don't deliver a 5-minute monologue and then expect the interpreter to remember all of it.
Now, connecting to that is health literacy. The text throws out a statistic that is honestly a bit shocking. The average American reads at a 6th grade level or below.
And that's the general population on a good day. When you add the stress of a sick child, sleep deprivation, hospital noise, and fear, that comprehension level drops even further. You cannot hand a parent a dense medical pamphlet written at a 12th grade level and expect them to understand it.
How do we assess if they aren't getting it? Because most people won't say, I can't read this, or I'm not smart enough to understand this.
Correct. There is immense shame attached to illiteracy or low literacy. So you look for red flags. I forgot my glasses, or I'll read it when I get home, or handing you back forms that are incomplete or filled out incorrectly. These are classic signs of low health literacy.
So what's the strategy? How do we ensure they actually know what to do?
The teach-back method. This is the gold standard. You don't ask, do you understand?
Because they will just nod.
They will nod every single time. You ask, in your own words, can you explain to me how you're going to give this medicine when you get home? I want to make sure I explained it clearly. You put the burden on yourself.
And visual aids, I'm guessing.
Visuals, videos, models. Show them, don't just tell them. The text says visuals are far superior to text alone. Circle the dosage on the syringe. Draw a picture of the wound care.
Moving into section 6. Teaching and learning principles. We have to teach the parents and the child, but they learn differently.
Right. For the parents, we rely on adult learning theory. Adults are self-directed and problem-focused. They need to know why this matters right now.
So not just, here's how to do the dressing change, but doing this dressing change correctly will prevent infection and help your child go home 3 days sooner.
Exactly. Give them the motivation. Connect it to their goal, which is getting their kid healthy and home. They need practical, immediate application.
And for the child,
it goes right back to development. For preschoolers, keep it short, use those soft words we talked about, and involve play. Let them put a Band-Aid on the doll. For school-age kids, involve them in the task. Let them hold the tape. Let them open the alcohol swab package.
it gives them that sense of control we talked about earlier.
Yes. It transforms them from a victim of the procedure to a participant in the procedure.
And for adolescents.
Collaborate. Treat them as a partner. We need to figure out a schedule for your insulin. What works best with your school schedule? Do you want to do it before lunch or after? If they help build the plan, they are far more likely to follow it. If you dictate the plan, they are likely to rebel.
That makes total sense.
Yeah.
Okay, we've covered a ton of ground here. We've looked at the philosophy of atraumatic care, the physical positioning like therapeutic hugging, the communication strategies from infants to teens, the vocabulary traps, and the whole family education piece.
It is a lot, but it all connects. It's a very holistic approach.
So let's wrap this up with our if you remember nothing else summary. If a listener is driving to their exam right now or walking onto the floor for their shift, what is the one mental model they need to hold on to?
The mental model is preparation, prevention.
Preparation equals prevention.
Yes. Whether it is choosing the right words, special medicine instead of dye, or choosing the right timing 1 hour prior for a preschooler, or choosing the right position, therapeutic hugging instead of restraints, your job as the nurse is to anticipate the fear and neutralize it before it starts. Don't wait for the child to panic and then try to fix it. build the safety net first.
That's powerful. It really shifts the nursing role from reactive to proactive. And I want to leave everyone with a final provocative thought that stood out to me from the reading. It's this idea of compliance versus alliance. Well, you have to ask yourself, are we just trying to get the kid to sit still? That's compliance, so we can get the job done quickly. Or are we building a relationship where they trust us with their body, an alliance? The source material really suggests that atraumatic care isn't just about getting through the shift. It's about building a trust that impacts how that child interacts with healthcare for the rest of their life. If you traumatize a 4-year-old now, you might create a 40-year-old who avoids the doctor until it's too late.
That is the so what. That's the whole point. We are shaping their future healthcare behavior. That is why this chapter matters so much.
Mic drop. All right, learners, take that do no harm mindset and go crush your exam. You've got this.
You've got this.
See you in the next deep dive.